Welcome back to the Dysphagia Matters podcast. I'm Julia and I'm sitting next to Julia.
Hello.
Today's episode is an especially important one because we're talking about health equity or inequity in dysphagia care.
Yes, and to help us unpack this, we're joined by Dr. Raele Loy from the Center for Health Disparities Research at the University of Wisconsin-Madison. Raele brings a critical lens to how inequities shape dysphagia care, particularly for people living with dementia.
She explains what health disparities mean in clinical practice and research today. She also discusses what is currently known about disparities in dysphagia assessment and management. Raele presents her conceptual framework about how disparities emerge and persist throughout the entire eating and drinking care pathway in people with dementia.
She also shares what an equitable dysphagia care pathway could look like, from early screening all the way through long-term management. And she highlights where equity-focused research is most urgently needed and what it will take to move our field forward.
Enjoy listening. Hi, Raele, and welcome to the Dysphagia Matters podcast. Thanks so much for joining us.
Thank you for having me.
Maybe to begin, could you briefly explain the focus of your research at the Center for Health Disparities Research and how you became interested in the field of health equity or maybe health inequity?
Yeah. So I work, as you mentioned, for the UW-Madison Center for Health Disparities Research, or CHEDR, as we like to call it here in Wisconsin. And the overall thing that we study or look at here in the center is the concept of the social exposome, which is essentially all of the types of things that people are being exposed to, both at a kind of broad level, all the way down to their personal life context throughout their lifetime. So you can think about things like climate, traffic, all the way down to their physical activity and diet, things like that. And how all of those different types of social and environmental exposures are then coming together to shape their health outcomes. So that's broadly what we study. And from that, I have developed an interest in the idea of treatment alignment. So ensuring that when we develop a care plan for somebody, that it makes sense within their life context. And I think this is a huge issue that I've seen in dysphagia management, where we prescribe diets or thickened liquids, and that may be so culturally unfamiliar. It may not work with someone's budget or the types of things they have at home for meal preparation. And so I've seen this idea of treatment misalignment come up a lot, where, even the most physiologically sound treatment plans can become ineffective or infeasible when somebody actually gets home. And so my work really centers on working with care partners, patients, hospital administrators to really figure out how we can start having those discussions about what someone's life context looks like a lot earlier in the treatment planning process, to ensure that we're sending people home with really sound recommendations. I got interested in this idea actually when I first came to UW-Madison. I was working on a research study with older adults, and I was trying to get frail older adults into the hospital. And I thought this would be really easy. But turns out they had so many different structural barriers. A lot of them were homebound, they were institution bound. And so there were a lot of kind of systemic systems level issues that I wasn't aware of. And then it just made me think, a lot of these frail older adults likely have dysphagia, but we have no way of getting to them to give them recommendations, to include them in our research studies. And so it just made me think, if we're missing right here, I'm at one of the most well-resourced universities and I can't get these older adults in. What about other places where it's not as well-resourced? What does swallowing and swallowing care look like in those types of communities? So that's really how I got started. And then I got connected to the center and its director, Dr. Amy Kind, and I've been working there ever since.
That's really interesting. And I think something, we probably typically don't really think about. So how would you then define health disparities, and why do you think they remain such a critical issue in health research today?
Yeah. So I think that the definition of health disparities is actually a really important one, because it includes two really important words right at the start. So oftentimes, if you look up health disparities, you'll see it described as preventable differences in health outcomes that are experienced by some socioeconomically disadvantaged groups. And whenever I give talks, presentations, I always like to put up this definition and highlight those first two words of preventable differences. Because the reality is that these disparities are conditions and circumstances that have been kind of created over time through different types of society norms or policies that just kind of have persisted over time and have left some individuals at a disadvantage over other individuals. But I think because they are preventable, since these systems were created, it means that eventually, if we work to enact some different policy changes or the way that we approach these patients, that we really can change the outcomes for a lot of these patients. So I find the definition important, where it's, very enlightening to understand that these are things that are happening and some people are disadvantaged, but it's also empowering on the other hand to understand that these are also things that we really can help change if we enact policy changes in the future. I think the reason why they've continued to persist is just because they're so big. They're so multifaceted. People often aren't disadvantaged in just one way. They're often disadvantaged in multiple ways. They have different things happening in their own life, but then there's also things happening at a broad kind of government society level as well. And it can be really hard and challenging, I think, to address all those different types of things. I think also too, disparities look very different across different communities, across different people. So, what may work in one situation, I do a lot of work here in Wisconsin, in rural Wisconsin. But if I go over to, New York or something where it's a lot of different types of people, some of the things that I find here in Wisconsin may not work for them, So I think that's also a challenge too, is just kind of the breadth and the depth of these disparities. I think that's why they've really persisted over time.
Thanks, that's very interesting. I was wondering whether you could give an example of these different factors that could also interact. What could this be?
Yeah. So I think I see a lot of this. Like I mentioned, I'm here in the state of Wisconsin, and a lot of our state is very rural. So people are kind of located far from the resources that they need. And so we see this a lot in rural communities where you grow up in a place where there's not a lot of stuff around. So you don't have as much access to things like maybe education or jobs. And so then when you grow up, you maybe have reduced health literacy because you didn't get the best education, but then maybe you also don't make as much money because there's not as many opportunities for jobs there. And then you also live in a food desert because you're very far from things. So then if a person who's living in that type of context then needs healthcare, they're going to have to try to travel very far to get their healthcare. They may not have specialty providers. So rural individuals, oftentimes they rely very heavily on emergency services rather than routine healthcare. Because it's very hard to get those kinds of things. And then when they get into those health situations, they may have issues with things like insurance coverage or paying out of pocket costs, again, because they have limited income. And then when you're sending them back into their communities, they may not have as many specialty services to upkeep their health care. So I think that's a good example of how it's just many, many things that start to accumulate and kind of compound over time just because someone's living in this kind of resource poor context.
Mm-hmm. And focusing in on dysphagia, what is currently known about health disparities in dysphagia assessment and management? What is your experience?
Yeah, so I think that compared to a lot of other really well-established fields, our understanding is still definitely emerging. So if you look at other fields like HIV or cancer research, diabetes, I mean, they have very well-established bodies of literature. I mean, thousands and thousands and thousands of articles about every single, treatment or whatever it might be. In dysphagia management, it's very different. So back in 2020, there was a scoping review that came out that looked at disparities across laryngology and related to deglutition or eating. They only found 8 articles at the time. So our understanding is very limited. Now, I'm feeling very hopeful because since that time, I've seen actually quite a few more articles come out. And I think what those articles and our limited literature base has shown is that we do have some disparities happening. There was a survey that found that racial and ethnic minorities were less likely to report dysphagia And then they also found a number of different structural barriers to care. So women and low income adults were facing a lot of challenges related to things like access or not having specialty providers, insurance coverage, things like that. I worked with Dr. Harrison Jones and his group down at Duke, and we found that in a big study of older adults that those who were homebound and food insecure were more likely to report dysphagia. There's also been some work coming out of Alabama looking at the lack of kind of specialty providers across the state. So I think that we see these different challenges related to things like insurance coverage, money, access to healthcare. We see that coming up in dysphagia management quite a bit, but I definitely think that we have a lot of work to do in our understanding to really deep dive a bit more into what are the issues and really where are people encountering the most problems accessing our types of services.
That's very interesting. And I imagine that it's also very difficult to research it because it may differ so much between, I mean, the US is a very big country, but even within one big country and then looking beyond in other parts of the world, it's even more challenging. So respect for this work. You developed a conceptual framework providing a novel approach to understanding how these health disparities arise and persist throughout the eating and swallowing care process for people specifically living with dementia. What are the most important health disparities in this field that you've discovered?
So when we did the conceptual framework, it really was born from our understanding that there is not a lot of research out there. And so we decided to do the framework to lay out what are the possible things that we think patients living with dementia and their care partners may be encountering at every single step of swallowing care. So thinking about screening, assessment, and treatment, what are the different types of barriers? And so we actually spent a really long time, Dr. Kind, who runs the center, and myself, she mentored me on this paper. And I just remember for probably about 8 months going to her office monthly and just literally with a pen and paper, just writing out all of the different things that we could think of. And then we started putting them together in this model. And so the model or the framework when it came together, that's exactly what it is. It's just the possibility, so it's not necessarily saying these are things that are definitely occurring or will occur, but it's just saying these are things that potentially could occur. And we thought about these on a couple of different levels. So we thought about individual level factors, so things like social support and some of the cultural things that need to be considered. We thought about systems level factors, so characteristics of the clinical encounter was a big one. So, if a provider doesn't have a lot of knowledge or if they have a bias, how will that affect someone getting swallowing care? And then we thought about community level factors. So thinking about the neighborhood that they're living in and whether or not it's well resourced, to accommodate their swallowing problems. And then we thought about a number of different factors like money and health literacy and healthcare access that didn't necessarily fit neatly on one of those levels, but could certainly apply to any of those levels. And I think what I really like about the framework is that right now it's kind of us as the researchers, the clinicians, saying this is our best kind of guess or our hypothesis based on what we know both clinically and from a research standpoint and based on the limited evidence base. This is what we think could be happening. But now we're going through the process of actually starting to engage in conversations with persons living with dementia, their care partners, and people who care for them to refine the framework even more to say, what are you actually experiencing? Which ones of these are the most important to you? Because I think it's important too to recognize that something that we may think is a big issue may not be a big issue for a patient. They may not define it as a disparity for themselves. So, for example, transportation, if you're living rurally and you don't have a car, that's a big problem. But if you're living in a metropolitan area and you can walk to places or take the metro, then having a car maybe isn't that big of a deal, or maybe it's not a disparity for you. So I think it's important for us to use the framework as a guide to, again, think about these are all the possibilities, but then really get the specifics about what patients are going through from their own experience and from their own lens. And we kind of let them define the disparities for themselves.
Looking a little bit broader, not only on people living with dementia, but in general, people with dysphagia. How do you think cultural beliefs around aging, eating, drinking, or maybe mealtime rituals influence a patient's engagement with dysphagia management?
I think it's a huge consideration, right? I mean, so much of our life is built around eating, and we build a lot of kind of routines and familiarity around eating. So much of our family traditions and things. I don't know, you all are in Ireland, right?
We're now both in Germany, but
Germany. Okay.
yeah.
So do they do Christmas in Germany? Because I know right now it's
Yeah.
okay.
Yeah.
So yes, it's like winter Christmas season right now. We just got off of Thanksgiving, so there's so many different traditions and things that come up for people. And so it's huge, right? We derive so much psychosocial safety and comfort and identity from being able to eat. And a lot of that stems from, our family, our culture, things like that. And this is why I think it's important for us to have an understanding of what those different types of things are. So that way we don't mischaracterize something as a disparity. So I remember when I was going to grad school to become a speech language pathologist, and we were learning about accents and accent modification. And our professors used to always say, remember, it's a difference, not a disorder. And I think about this a lot when it comes to a lot of these cultural things. There are some cultures where they want to eat with their hands. That's just a difference. It's not a disparity. It's not a disorder. There are, some cultures where they have specific ways that they approach decision making in those cultures. And so if you're working with them, then you have to respect those kinds of things. And, oftentimes I'll take it back to the dementia world for a second. Something that gets characterized often as a disparity in this world is that a lot of racial and ethnic minorities care for their loved ones at home versus putting them into like a nursing home or something like that. And yes, I think it can be argued that some of that does stem from disparities that may be related to income or insurance coverage or whatever it might be. But, there might be something within that culture, that family that really works in that model to keep their loved one at home. So is that, a disparity, or is that just kind of a difference? So I think it's really important to appreciate that we do have a lot of these meaningful traditions and identities built out around culture, and respect that during our management process to make sure that we are honoring it and not maybe mischaracterizing it as something that it's not.
Yeah, and so maybe before we actually start treatment, when we do the assessment, we probably need to find out what are potential differences, because we might assume a lot, but oftentimes I guess we don't really know.
Yes, yeah. I think it's a huge consideration just to, let your patient kind of guide that conversation and find out. One of my favorite questions I ask patients, where I feel like I can get a lot of this information without being too direct, is I always ask them about their favorite meal, because I can find out from that a little bit about maybe some of their culture, because sometimes, here in Wisconsin, that we eat a lot of dairy foods. That's the culture here. A lot of people live on farms. So you find out about that. But then I can start asking them questions about, oh, if you wanted to make, your pot roast or something, how do you get the ingredients for that? What store do you go to? Does anybody help you make that food? When do you typically eat it? So you can start getting all these different questions. And patients really like when you learn a little bit more about them and what they're actually doing at home. So I think it's great to just start with some of those questions where you can figure out where are they coming from in terms of their cultural food identity.
Yeah, I like the way you phrased the questions. More, yeah, like you say, more learning about the patient than assuming or just, yeah, saying, okay, this is the way we do it. So I guess you do it the same way.
Mm-hmm, mm-hmm.
You have mentioned racial and ethnic minorities. I feel these terms are often used interchangeably. Could you briefly explain what the difference is?
Yeah, I think they are used interchangeably. So race is basically concerned with like the physical things that are grouping people together. So the physical traits. Whereas ethnicity is a bit more concerned with the cultural kind of characteristics of someone and the types of, I guess you could say, like culture or like social groups that they end up belonging to. But it is a very important distinction, and it is something that does get widely talked about. And I would say as well, too, it's often talked about in disparities that racial ethnic minorities tend to experience these disparities and these different disadvantages disproportionately to other groups. And I think for a long time, there was this misunderstanding around it that it had something to do with being a biological difference. But we have really come very far in our understanding, and we understand that a lot of it is owed to social conditions, not biological ones. So I think that's important when people are doing things like reporting race, ethnicity in their research or in their papers. Those things do have to be interpreted with caution, because we can't attribute the differences to it somehow being about, well, this person's Black or, Latinx, whatever it may be. We really need to think about the social conditions, the bigger conditions around that person, and how that's perpetuating the disparity. So that is something important to think about in this work that we're doing, because I have seen that a little bit in the literature, where people tend to just kind of not go beyond the surface with some of these things. And that can be kind of harmful, right? If you're mischaracterizing groups based on incorrect information. So it's a good question. It's good to understand those differences.
Can you maybe share examples how structural barriers like insurance, transportation, or access to specialists have directly affected swallowing outcomes, maybe in your clinical practice and or research? And you've already touched on this a little bit in the beginning.
Yeah. I mean, I think the most eye-opening experience I had was with my research study, where, again, I was trying to recruit non-frail, pre-frail, and frail older adults. And I did really great finding the non-frail older adults. Pre-frail is a little tricky because they have to be kind of starting to have some problems, maybe like slower gait or reduced hand grip strength, but they also still kind of have to be in the community a little bit too. So they're kind of an interesting group to capture. And then frail older adults, I think, is, they're more medically complex. So it was really hard getting them in. So I ended up actually partnering with a rural nursing home. And that's where most of my frail older adults ended up coming from. But we weren't able to do a single swallow study on these older adults because a lot of them were wardens of the state. So it meant that they were under the care officially of kind of the state. So they maybe didn't have care partners involved. And so the state now kind of was in charge of their care, essentially. So it would have been really hard to get the state to maybe consent to have them leave the building to come, get a swallow study done. There were also, just at that site as well, I worked with the speech pathologist there for a while, but then she ended up leaving. And then she was in a different state, but still kind of working remotely with some of those patients. So you kind of started to see too, for a lot of these patients, how it became a challenge to even get the necessity care that they needed, right? Not even this research care. They needed, actual swallowing care. And it was really difficult to obtain that. And then I think, it was also just a challenge to think about, if we somehow were able to get these patients to the hospital is like an hour from the site. How are we going to get them there transportation wise? Who would pay for that? All of these different types of things. And then I thought a lot about, we always like to say that we like to close the loop in research. So if we're working with healthcare providers and then we do a research study, how can we close the loop and come back to clinic and use these findings to help this patient? And it was going to be really challenging to close the loop with a lot of those patients because, again, the site just wasn't set up for swallowing care, really. Didn't have, a number of SLPs there that could work with the patients and provide that type of care. There's a lot of things that happen in nursing homes. It's, a very unique environment. So a lot of different challenges, but what was also very kind of eye-opening about that experience, we just did the initial data analysis. Every single one of those patients that I saw had a clinical sign of dysphagia. They all failed the 3-ounce water swallow test, and they all had values that were outside of the normative limits on the TOMAS, the test of masticating and swallowing solids. So I think it raises this really interesting question of, patients that really need our help and are frail and are medically complex, but then also have these types of health disparity challenges. How do we reach them? Because I don't think that our research studies right now are necessarily designed to capture those kinds of patients and really offer approaches for those kinds of patients. So it's left me with some interesting questions about what to do next.
Yeah, and still these patients are the patients that we are supposed to make the management and plan the management. And yeah, so actually that's the problem, that we don't know how to treat them best because we've never researched them.
Mm-hmm. Right, exactly. So we have to figure out, I think, more ways to reach into these types of communities and think about some really, different ways that maybe we can approach. So something we've been looking more into are mobile swallowing clinics where we can, go drive and just park the swallowing unit right outside the door. But even with that, I think there's a lot of logistical challenges or things to think through. So it's a big, big challenge.
Yeah, I imagine. Next to the mobile swallowing clinic, if you could redesign the dysphagia care pathway to make it more equitable, what would be your top priorities?
Yes. So I think that through my research so far, and then I think reflecting clinically as well, I think that what I've come to appreciate is that a lot of the points of misalignment that I see happening in our field really are happening at the systems level. And so it's a lot of challenges, at least here in the States, with our healthcare system itself. So we don't, I think, employ a lot of times enough speech language pathologists to make this work happen. I think that the way that we tend to take care, particularly of older adults, because that's what I specialize in, it's very fragmented. So you go and see, your primary care provider who then has to refer to this specialist and then to that specialist. And then hopefully at some point someone mentions the SLP, but we're not directly embedded into a lot of these teams. And we also recently did, well, we have it under review now, this survey paper where we surveyed individuals working in geriatric medicine who weren't speech language pathologists. And it was very interesting to see that a lot of them were using techniques within their clinics that really aren't like evidence-based to try to find these patients. They really weren't working with a lot of SLPs. I think just thinking about all of that, I would want to prioritize redesigning the system, I think, entirely, where we could truly have more multidisciplinary teams that include SLPs, where we're really thinking through these patient cases together. I think I would also want to figure out ways where we could have more time. That way we could really engage in more conversations with patients about what is your life context? What are the things that you're being exposed to? And I think I would want some tools or resources that could kind of help guide those types of discussions as well. Because I think that, it's easy to collect patient reported outcomes, but I think it gets harder to think about what do I actually do with this information. So I think that if there were ways that we could think about, if I'm interviewing a patient and getting this information, how can I really translate that into my care plan? So those are the things I think about. How can we get SLPs involved earlier and as part of the more multidisciplinary process? And then how can we have more approaches that really allow us to investigate or understand the patient's lived experience a bit more?
Do you think that to bring the SLP in to the care plan earlier, that we first need to raise awareness of dysphagia? Even like sometimes I feel that's the actual problem, that if the other disciplines would know maybe more about dysphagia, they would think maybe sooner about it and then also about bringing the SLP in.
Yes, I think you raised such a good point, is that there is a really big lack of awareness, both among, I think, healthcare providers, but also a lot of individuals who are just out
Yeah,
here.
true.
We've worked a lot with communities. I work here as well with Dr. Nicole Rogas-Palia and her swallowing and salivary bioscience lab. And we go and we do community presentations. We go to local nursing homes. And it's just, I think, been very eye-opening for us how many of those community members are like, oh, am I not supposed to be coughing at every meal? Oh, I didn't realize that. And, and then we're able to provide that education. But I think it's a big issue, again, in these communities. But then, yes, with a lot of healthcare providers, I mean, when I was setting up my study, I talked to a lot of geriatricians. I go to a couple of geriatric medicine meetings every year. And I think what's been interesting is that there's this perception of, oh, I work with this speech pathologist, but I wait until like my patient definitely has dysphagia. And I'm like, yeah, but if you have a patient that has dementia, and at some point it's very likely they're going to, like, why not just refer when you first see them? So I've had some interesting conversations about that as well. I think one of the big things that we need to work on as a field that could help with a lot of this is I think we need to really shift our focus into making eating, drinking, dysphagia a public health issue. Because, when older adults, start to age, they get very concerned about things like falling and, losing their ability to hear or think. Because these things are considered public health issues, right? Like we have whole fall risk campaigns in hospitals and things, but we don't have dysphagia campaigns at that level. People really aren't talking about, oh, I wonder what's going to happen to me if I can't eat or drink, because they don't have the awareness that that's even something that could happen. So it's not about, instilling fear, but I think it's just about making people aware that, this is something that we should be planning for too, because it may happen either as you get older or if you develop these different types of conditions. So I think we need to get this into the kind of public health sphere a bit more and really work on getting that education out there.
Yes, absolutely. And we know about all the negative consequences of dysphagia. So it's nothing new, at least to us. So yeah, it sounds quite easy and straightforward, but yeah, it isn't, unfortunately.
Right.
So looking at research, what areas of dysphagia research are most urgently in need of equity-focused investigation, in your opinion? So you've talked already about dementia care, for example, or do you think there should be more investigations in rural communities or racial ethnic minorities, caregiver burden? What do you think?
Yes, I say yes to all of the above. I think the reality is just that we need more. We need more research, because I think it gets easier to do things like advocate for changes in policy if we really would have data to show, these rural adults can't get the care that they need, or these individuals living in this part of the world can't get the care that they need. But it gets harder to have those conversations if you're just like, that's my best guess, and you don't have anything to really back it up with. So I think that we have so many different directions that this work can go, and like I said, I mean, we're just really, I think, starting to ramp up in our understanding, but the reality is I think that we're behind. So we just really need to catch up. And I always just encourage people as well with the research that is coming out. I think that we need to, as consumers of this research, maybe hold the researchers, but the journals a little accountable as well, because, we should really be past the point where people aren't reporting the basic demographics around race, ethnicity, income, those kinds of things. Because if you read the research and you're not really sure who the patients are, then you're not really sure how it applies to the work that you may be doing. So I think that we all need to be a little bit more kind of transparent in our reporting, and maybe gathering some more of this information and sharing it. I think we need to do a better job, like I was saying, reaching out into some of these communities that aren't traditionally represented in research, or who may not be coming into your clinic very easily. We may need to go into some of these other neighborhoods and start engaging in some of those conversations. So I think that there's a lot of work to be done. I've already accepted that I'm going to be spending the rest of my life doing this, and I'll probably make it 1% better, because I think there's just so much to accomplish. But I think that if we all just kind of start doing, 1%, that could start to add up, right? So I think there's just a lot to be done.
Yes, absolutely. And thank you so much for your excellent work that you are already doing. And maybe you motivated someone else to do the same work. Thank you so much, Raele, for taking the time to share your valuable expertise with us and our listeners today.
Thank you for having me. This was really fun.
Thanks so much for listening. If you enjoyed this episode, leave a review wherever you listen to podcasts. You can connect with us on Instagram, LinkedIn, and Blue Sky, or visit our website, dysphagiamatters.org. We'd love to hear from you. Until next time, take care.